right, hello everyone. Welcome to today's live virtual event. I'm Jen Aliano. I'm the Director of Grassroots Health. And let me share my screen here. So again, this is our virtual 2024 International Vitamin D Expert Forum. I will be going through the agenda in just a second, but first I wanted to start by dedicating this event to Carol Baggerly, who founded Grassroots Health in 2007 by forming the Call to D-Action, a consensus statement signed by 40 international senior vitamin D researchers who agreed on recommending a 25 OH vitamin D serum level of 40 to 60 nanograms per milliliter to support optimal health among the general population. These top researchers agreed that supplementing with doses of vitamin D to support this serum level was a safe, effective, and inexpensive way to promote health and lower the risk of disease. 17 years later, we are here today to demonstrate further research in support of that message and as a response to the latest Endocrine Society update, which Dr. Hollick will be addressing shortly. I would also like to dedicate this event to Dr. Robert Haney, past research director of Grassroots Health, and Dr. Cedric Garland, principal investigator of the Grassroots Health Vitamin D Action Study, as well as all of the other amazing scientists who have dedicated much of their lives, which is many decades in combination, to vitamin D research, and several of them, I am happy to say, are here today. As a collaboration of scientists, health providers, educators, and others, Grassroots Health continues to strive to move this research into practice and educate individuals on how to implement the research into their daily lives to improve health, which is one of our key goals for today. So I have a few reminders before I hand the spotlight over to Dr. Richard Chang. This is the live portion of what we are calling an ongoing event. We will be releasing recorded presentations and sharing papers in support of the material presented here today. Please be sure to visit grassrootshealth.net and orthomolecular.org for access to those videos and papers. Once again, today has a very condensed format, and there will be much more information shared that will be available online following this live forum. A note about our upcoming question and answer session. Questions for our panelists have been submitted prior to today, some of which will be presented here during our Q&A, but many of which will be answered following the forum. Questions can also be submitted here via the chat on Zoom or the Q&A. We are not expecting to get to all questions, but we will review them following today, and we will be posting the answers online. Here's a quick look at today's agenda. We have 2 hours. I'm going to be turning it over to Dr. Richard Chang in just a moment. Following that, we will have Dr. Michael Hollick speaking on the overall quality and shortcomings of current vitamin D research and guidelines. Dr. Sunil Wimalawansa will be discussing basic concepts important to understanding vitamin D. Next, we will go through just a few of the practical and clinical uses of vitamin D. And I do want to note, unfortunately, Dr. Carol Wagner will not be able to join us this morning, but she will be recording a full presentation to share after today's event. We will then go back to Dr. Wimalawansa, who will discuss vitamin D safety and contraindications. Following that, we will have our interactive question and answers with our expert panel, followed by closing remarks. So with that, I will go ahead and turn it over to Dr. Richard Chang.
Thank you very much, Jen. Thank you for all the experts. We are very glad that the experts of the international the top quality gather here together to clear a few confusions about vitamin D for the general consumers and the practitioners in particular. So without further ado, I will hand over the time over to the experts. And at the very last, in the closing remark, hopefully I will have a few slides to share of my learning from the experts and the years of experience and how we apply them in clinical medicine, how it will benefit the general consumers. And Jen, over back to you.
Thank you, Dr. Chang. And now I'm going to give the floor to Michael Hollick.
So it's a real pleasure to have this opportunity to share with you my thoughts about the delightfully controversial vitamin D and its health benefits from inception until death, and the 2022 perspective. People worry about conflict of interest, and so I receive support from a variety of companies as a consultant and other activities. And I also get support from the Sun. And you can go to this website to get more information, at least about what I've been talking about, vitamin D. Now, what am I going to tell you that you don't already know about vitamin D in terms of the IOM report, the Vital Study, 2024 guidelines? So 2010, the IOM came out with recommendations. And in my opinion, they were quite remarkable because before 2010, the RDA was 200 units, and they suggested up to 600 units was fine. And more importantly, they appreciated that 2,000 units was considered to be the upper limit. Now you could at least take 4,000 units a day. The IOM guidelines, however, was not intended for physicians, right? It was up to professional associations to make these recommendations, and they used a population model, not a medical model. In 2011, the Endocrine Society reported guidelines on vitamin D, and I was fortunate enough to chair this committee, and all the members of the committee are experts in the field of vitamin D, and as you can see, Dr. Heaney was a member as well. And the objective was clear: for the prevention of vitamin D deficiency with emphasis on care of patients who were at risk of vitamin D deficiency. So 2011, the recommendation for infants up to 1 year of age, 400 to 1,000 units a day, children, 600 to 1,000 units a day, and adults, 1,500 to 2,000 units a day. And if you're obese, you need 2 to 3 times more. Endocrine Society guidelines for 2024. Overt vitamin D deficiency, they recognize, can cause rickets and osteomalacia. In population observations, lower 25-hydroxy-D concentrations are associated with a higher risk of undesirable outcomes, fractures, infections, cardiovascular disease, cancer, and mortality. Whether vitamin D supplementation reduces these risks remains unclear. A priori decisions made by the 2024 guidelines focus generally on healthy populations, assume that the RDA by the IOM was in fact correct, and so 600 units up to 70 years of age, and that includes pregnancy, 800 units when you're 70 years and older. Since observational studies are susceptible to bias and confounding, the panel focused mainly on RCTs, whenever possible, focused on patient-important outcomes rather than other outcomes, including association studies. So they didn't recommend any vitamin D supplementation for infants. 1 to 18 years of age, 600 units, 18 to 75, 600 units. And if you're obese, they don't recommend any different change. And for 75 years and older, if you want to live a bit longer, they suggested 900 units a day. But did they get it right? Right, here are the guidelines. They depended on randomized controlled trials, ignored association studies. And so I think that Ignaz Semmelweis would be, even back then, had appreciated that that's a bad idea. And so here's recommendation 8 from the 2024 guidelines. We suggest empiric vitamin D supplementation during pregnancy, given its potential risk for lowering preeclampsia, intrauterine mortality, preterm birth, small gestation for age, and neonatal mortality. And they recommended, on average, 2,500 units a day. Wow. That's amazing to think about this, that they actually recognized non-skeletal health benefits of vitamin D. So what about pregnancy? Are pregnant women at risk if they're taking a prenatal vitamin? And so we did a study at our hospital, and we documented very carefully them taking a prenatal vitamin and drinking milk. They were drinking 600 units a day from diet and from supplement. That's the amount recommended by the Institute of Medicine and now the 2024 guidelines. And we showed 76% of moms, 81% of newborns were less than 20 nanograms per ml. They were vitamin D deficient. Why should you care? Because we went on to show with Lisa Bodner many years ago, preeclampsia is associated with vitamin D deficiency. We also demonstrated that vitamin D, critically important for muscle function and birthing, that if you're vitamin D deficient, you had a much higher risk of requiring a C-section. Could you have been delivered later if mom had taken vitamin D? And a very nice study demonstrated gestational age and 25-hydroxyvitamin D, remarkable 60% reduction in premature births if the blood level was greater than 40 nanograms per ml. Mom, thanks for taking your vitamin D. Prenatal vitamin D and dental caries, inverse relationship with the amount of decay in infants with higher 25-hydroxyvitamin D during pregnancy. But recommendation 8, we suggest empiric vitamin D supplementation during pregnancy, right? There it is. But yet, they say, a priori decisions, general approach, including pregnancy, they recommend 600 units of vitamin D a day. There's a disconnect because here on one hand, they recognize the non-skeletal health benefit during pregnancy, but yet they don't recommend that all pregnant women should increase their vitamin D intake. How do you define vitamin D deficiency? Right, you want to measure your 25-hydroxyvitamin D, and anything lower than 20 we consider definitely to impact on bone health. But people worry about, is it high, is it normal, or is it low? And so for those that are high, Baywatch babes, right, they're 110, right? Lifeguards, are they intoxicated? I don't think so. You don't have to worry about intoxication until you're over 150 nanograms per ml. But the lower limit, how do you know if you're vitamin D deficient? Do you really need to be greater than 30? So we did a study with Ann DePape many years ago and showed PTH levels continue to decline until you get to around 30 nanograms per ml. You have a 3 times higher risk of having secondary hyperparathyroidism if your level is 21 compared to greater than 30 nanograms per ml. We also asked another question about sunlight and the variability in your PTH and 25-hydroxy-D, 3.8 million samples, and showed, as expected, your peak blood levels are at the summer and naters at the end of winter. And your PTH levels begin to increase and maximize 4 weeks later. And the real question is, the levels are at around 29 nanograms per ml at the end of the summer, compared to around 18 to 20 nanograms in the winter. There's no question that when you're vitamin D deficient, less than 30, that your PTH levels will continue to rise at the lower levels. We also know something else, which is a study done in 2010 by Prenatal, looked at 675 German motor vehicle accident victims and got blood for 25-hydroxy-D and bone and showed, here's normal bone, here is osteoporotic bone where you see no trabeculae, but here you see normal trabeculae and pink stuff. That's osteoid. That's classic for vitamin D deficiency rickets. And here in healthy German adults, ages 20 to 90 years of age, almost 27% and 37% had evidence of osteoid osteomalacia or osteoidosis, which is osteoid buried within your bone. And they concluded, the IOM, that if you take this number of those between 21 and 29 having osteomalacia over the total as a denominator, less than 1% had osteomalacia. So they concluded you only need to be 20 nanograms per ml. But Premal said you needed to be greater than 30. And in fact, they made a high school error in judgment, right? You should be taking this as your numerator and this is your denominator, meaning that adults with a 25-hydroxy-D of 21 to 29 nanograms per ml, 22% had osteomalacia, right? And so this is the preferred range that you've already heard from Jen, is what the Endocrine Society recommended in 2011. Does vitamin D reduce risk of fractures? Well, now the VITAL study came out, right? And oh my gracious, now it's suggested that people should stop taking vitamin D supplementation to extend life or have any major impact on your health. It's over 25,000, right, separated into what's called a placebo group and a group getting 2,000 units of vitamin D a day. The problem with the study is manyfold. One of them is they're permitted for the placebo group to take at least 800 units a day. But if they take a multivitamin containing 800 units a day, they could be taking up to 1,200 units a day. Look at this. Baseline 25-hydroxy-D in this whole group was 30 nanograms per ml. 64.7% had a 25-hydroxy-D of at least 30. What percent were less than 20? Shockingly, only about 12.9%. Indeed, this study showed very clearly that only those that were severely vitamin D deficient, but 2.4%, a very small number, they couldn't really make any sense out of whether or not there was any impact on osteoporosis. They made it clear that this study was not to be associated and reflective of vitamin D deficiency for low bone mass or osteoporosis. It was not a placebo-controlled trial. Therefore, 87.1% were considered sufficient, greater than 20 nanograms per ml. Recommendation: children and adolescents should think about taking empiric vitamin D supplementation because the clinical trial suggested that it may help reduce risk of respiratory tract infections, 1,200 units of vitamin D a day. Now, what about for COVID, right? And what about for adults? What about all of the data that's out there regarding infectious diseases in adults? We know vitamin D plays a critical role in innate and adaptive immunity. We know that these are nice theories, but what about the data? And it turns out that we did a study in over 190,000 patients during early COVID and showed if you're vitamin D deficient, you have a 54% higher risk of acquiring COVID infection. Study done in San Francisco showed very nicely hospitalization, that you markedly decrease risk of hospitalization by 22% and mortality by 45%. We did a study at our hospital and showed if your vitamin D is sufficient, overall odds reduction of death, 82%, right? But the general population, the recommendation for younger and aged than 50 years, we suggest against empiric vitamin D supplementation. Those over, we suggest against routine 25-hydroxy-D testing. Beta islet cells have a vitamin D receptor. We know that 125-D regulates insulin production. Pitta showed many years ago a clear association with increased risk of type 2 diabetes, relative risk reduction 33%. Another study that was done showed that meta-analysis, type 2 diabetes, broad range of blood levels in diverse populations, significant association. For adults with high-risk prediabetes, the 2024 guidelines recommends that you should take empiric vitamin D. And they suggested on average about maybe 3,500 units a day. Recommendation 2, though, the general population, younger than 50, they don't recommend empiric vitamin D supplementation. So how do you know if you're going to get prediabetes or not, right? 1/3 of the population has type 2 diabetes, right? The general population, again, no testing for 25-hydroxy-D. Can you live longer, right? Here's a very nice study by Cedric Garland several years ago. Again, maximum benefit and reduced risk of mortality, 40 to 50 nanograms per ml. And so, yes, the 2024 guidelines suggested empiric supplementation, but only about 900 units of vitamin D, and yet their normal recommendation is 800 units. But the real issue is, it's silly, in my opinion, to be worried about mortality at the age of 75 and taking more vitamin D. The vitamin D effect reduces risk of cardiovascular disease, cancer mortality, etc. And that's earlier in life. And so as a result, the general population of 75 years of age, an increase in vitamin D may improve their mortality, but you care about improving mortality by maintaining vitamin D from birth until death. And again, just looking at vitamin D deficiency and disease of neglect, right? It's necessary, right? A mountain of evidence looking into these chronic illnesses and thinking about all the different types of disease burdens associated. Don't think about a normal level, but a healthy level. You want to be at least 30 nanograms per ml. And here's a good example of here at Masai herders, 40 to 50 nanograms per ml, right? You would have to take 4,000 to 5,000 units a day. Goal, 30, preferably 40 to 60 nanograms per ml, right? So poor Ignace, right? Here he is. He has a stamp and a gold coin. He even has a medical school in his name. He instituted hand washing back in the 1840s. He thought that this was a great idea, but his thought leaders thought it was bad humors in the air and it was a bad idea. And so he even demonstrated an association study. Thought leaders, women and babies are dying, and if you wash your hands, essentially no one dies. What did they do? They were so angry with him, they said he was crazy. They committed him to an insane asylum. They had the guards beat him up, and he died 2 weeks later of infectious disease. Vitamin D deficiency is the most common medical condition. Any one of these chronic illnesses turn out to be associated, right? Even Dr. Joanne Manson says 2,000 units a day, safe for many years, right? Many benefits. But if you have a higher BMI, maybe not. And so we do need to look more carefully at the effect of obesity. So you want to reduce risk of various disorders, association and other studies, 40 to 60 nanograms per ml. Preeclampsia, more than 50%. Preterm birth, 62%. Autoimmune disorders, 39%. Metastatic and fatal cancers, 38%. Type 1 diabetes, 81%, 88%. And advanced type 2 diabetes, 76%. And peripheral vascular disease by 80%. Respiratory tract infections, 58%. Vitamin D can improve your health. No question about it. And I thank you for your kind attention.
That was excellent, Dr. Hollick. Thank you so much. Next, I would like to invite Dr. Sunil Wimalawansa, who will be covering some basic concepts about vitamin D. Please note that Dr. Wimalawansa is recovering from a vocal cord injury, and he may need to speak a little softly to protect his voice. However, his full presentation has already been recorded and it is live on our YouTube channel, and we will be sharing it shortly after today's event. So with that, thank you for being here with us, Dr. Wimalawansa.
Thank you, Ms. Aliano, for inviting us to this excellent program. So I'm going to continue what Professor Hollick discussed so far to complement some of the aspects essential to understand using and how to use vitamin D to make it more effective. Now, vitamin D consists two other metabolites which is commonly used. The parental component, of course, is vitamin D. The human version is D3. So once it gets hydroxylated, it becomes converted to calcifidiol, which is generally happen in the liver, but the vast component of this also happen in the peripheral target tissues, which we'll address in a few minutes. And then that will get further hydroxylated to become the most potent vitamin D component or metabolite, calcitriol. Again, this happens in the kidney and produces and releases the hormonal version of calcitriol, but it is unquantitated, but vast amount of calcitriol also produced within the peripheral target cells. So there are many analogs based on vitamin D or 1 alpha that used in renal failure, which we are not going to address today. There's one analog of 25-hydroxy vitamin D, which is no different in a clinical point of view. So, replacement point of view, vitamin D3, the prenatal form, is the number one way to move forward. So, vitamin D is not a hormone, but it's a threshold nutrient. Very important to follow this fundamental concept that introduced by Professor Heaney and colleagues, because the curves for pharmacological agent and the nutrients are vastly different. Secondly, the people with the darker skin colored need more duration of the sun exposure as melanin filters out most of the vitamin, so UVB rays. Thirdly, overexposure to sun UV rays can cause erythema and skin damage. And again, Professor Holick has published multiple papers on regarding this, educated not to get into that erythema kind of exposure, because in the long term, it can lead to skin cancer. Nevertheless, excessive sun exposure almost never produces excess vitamin D to cause hypercalcemia, as they get degraded within the skin itself. So this has been discussed in details and available at the grassrootshealth.net in a discussion fashion. So functionally, there are two discrete vitamin D systems. It's easy to understand if you follow this way rather than putting all vitamin D in the same basket. Firstly, the well-studied endocrine systems people have published for the past many decades on that, predominantly concentrated on the calcium metabolism. But there's another aspect, or the more important, in fact, is the genomic effects, intracrine, paracrine, and even the membrane action of vitamin D, which is not depending on the endocrine functions of vitamin D. They're completely separated. The endocrine system is a primary function is a calcium and mineral homeostasis, whether it's intestinal increased absorption or renal protection for the absorption of reabsorption of calcium, and again the fat, bone, and muscle cell storage. So for endocrine function, which is conversion of 25-hydroxy D to calcitriol, is primarily occurs in the renal tubular cells, and that excretes back to the serum or the bloodstream as the hormonal calcitriol. So difference is that these tissues mentioned here has a megalin-tubulin acute transportation system in addition to the endocytosis. So that 25-hydroxy D, although it's a vitamin D binding protein bound tightly, they have a mechanism to get actively reabsorbed into these renal tubular cells, so as a muscle and fat cells. Therefore, even though the concentration are lower in the circulation, they have a preferential effect of absorbing 25-hydroxy D into the renal tubular cells. So that is an important consequence of this one, because even with the significant vitamin D deficiency, which a low 25-hydroxy D would be 10, 12, 15, that serum 125-hydroxy vitamin D could be still normal. So measuring 125-hydroxy vitamin D is a complete misnomer and impossible to interpret and should not be done. So the second part, the peripheral target tissue-based vitamin D actions, mostly depending on the vitamin D and some parts of 25-hydroxy D, based on this diffusion capacity from the circulation into the target cells like immune cells. So higher the proportion of the vitamin D in the circulation, and it's because of these free components are higher, the more vitamin D actually gets into the peripheral target tissues. But both vitamin D and 25-hydroxy D enters peripheral target cells and get converted intracellularly to calcitriol for its intracrine, paracrine, and genomic actions. So in peripheral target cells, it's important to have the adequate number of D3. Nevertheless, the half-life of D3 is only 1 day. So that gives reason why vitamin D is best taken on a daily basis to maintain the steady D3 level in the circulation. Or preferably, one can get a daily sun exposure doing the same thing without spending a penny. So taking vitamin D intermittently, based on what I said just now, is not the optimal solution. But we know that from the data, the published results, once a week administration does work as equally as once daily. But once in 2 weeks, once a month, and beyond is not optimal, and in fact can cause unnecessary issues. So 25-hydroxy D, the calcifidiol alone, should not be taken as a supplement, as all these better important function will not be able to facilitate it. Now let's briefly address the vitamin D as a threshold micronutrient. This slide shows the administered dose on the x-axis in the arbitrary unit and the biological responses on y-axis. When somebody is vitamin D deficient, giving small amount of vitamin D really doesn't make a difference. Then even up to about 10, 15,000, because their biological action will not get activated until there's a certain amount of levels in the circulation appears. Similarly, when they are near sufficient or sufficient vitamin D, giving additional vitamin D again is superfluous and is not have a beneficial effects, except in a very small component of patients. So, in summary, vitamin D responses rate diminishes as the blood level increases towards its sufficient level. So once it's reached the plateau, there will not be any additional beneficial effect by taking extra supplement, as Dr. Halleck just showed you from the vital study. The subjects are already sufficient vitamin D. How on earth they can get even better? So taking minimum of 30 nanograms per ml as suggested by the Endocrine Society guidelines in 2011 is reasonable for maintenance of some of the activities like muscle, bone, and quite a few metabolic disorders. And in our estimation, it covers only 50% of the health of human needs. So fundamental of vitamin D is considering the metabolic disorders like diabetes, obesity, etc. The 40 nanograms per ml seems to be the reasonable amount to achieve for. So that is estimated to cover something like a 75% of the human needs of vitamin D to overcome disorders. Don't forget that both D3 and 25-hydroxy D are both involved in the protection of the body systems. Second important point is actually serum 25-hydroxylation will not help my apology. Going back. So the protection against infection and autoimmune diseases, and including the cancer prevention and others, concentration above 50 nanograms in mils are necessary, as shown by many recent publications. And the therapeutic range between either 40 or 50 to 80 nanograms mils, we estimated that covers something like a 99.9 of the all human disorder. So this is what we need to be target for, what I call is a physiological target range. So I'm going to illustrate this by this Dr. Heaney's chart, which is from the Grassroots Health, showing the same thing. Here, what you're looking at is the intake or perhaps serum levels and their responses in the y-axis. So for the bone health, you need a certain amount of vitamin D intakes, maybe 1,000, 2,000 units to get the 50% effect. Whereas in the perinatal health, the metabolic disorders, and many other conditions, you need a higher intake and higher serum 25-hydroxy level. Whereas the immune health in particular, covering the infection, cancer prevention, longevity, and most of the autoimmune diseases requiring more than twice the amount necessary for serum concentration necessary to better responses. So here's a chart I produced from actually using the data from something like 900 different published studies to summarize what I just said. Basically, around 15 to 20 nanograms per ml, calcium metabolism can be worked out and can prevent the osteomalacia in adults and rickets in children. In here, what you're looking at is the percentage reported risk reduction based on the serum level. As you see, with some disorders like osteoporosis fracture prevention through the prevention of secondary hypoparathyroidism require 30. That's where again, Professor Michael showed that actually its cutoff point for PTH deflection is about 30 nanograms per mil, whereas robust innate and adaptive immune system and cancer and the sepsis prevention, you need a higher concentration. Again, as I said earlier, there is a small component of something like 0.01% of the population who has the resistant disorders and drug-resistant asthma, autoimmune disorders, psoriasis, cluster headache, migraine headache, etc., going to need much higher concentration of vitamin D, including up to 100, 125 nanograms per mil. Nevertheless, this must be administered by the experts who are really familiar with using high dose of vitamin D, at the same time curtailing or taking very low calcium diets. So considering this, the claiming that the 20, 30 or 40 minimum levels necessary is, I think, is misleading. Whereas if you take the minimum levels at 40 or 50 at least, that should cover, as I said in the previous slides, 99.9 of the disorders affecting the human being. That's the kind of minimal levels we need. With the range of 50 to 80, that guideline, that goal can be achieved. Thank you. Back to Jane.
Thank you, Dr. Wimalawansa. Okay, so let's see here. Who is next? All right, so this next portion is a summary of practical and clinical uses of vitamin D. And our first speaker, I'm going to let Dr. Richard Chang introduce. So Dr. Chang, will you please introduce Dr. Ning?
Yes, thank you. Thank you, Dr. Ning, for joining us tonight. Actually, it's late here in Beijing time. It's 10:40 p.m. And Dr. Ning had a busy day today and still is up and sharing his thoughts on this portion of the program with us. Dr. Ning, Dr. Zhiwei Ning is a professor and chief of Department of Endocrinology and Metabolism in Beijing, the Capital Medical University, and the Chaoyang Hospital. And he's published a book, at least one book on vitamin D. He's well known in China. As far as I know, he's probably the best known vitamin D expert here in China. And he's done a lot of research studies on particularly Chinese population on vitamin D and associated diseases, particularly in terms of bone health. And he's going to share some with us, and he's going to show that the vitamin D deficiency, insufficiency is even more serious in China than here in the United States. Dr. Ning, please.
Thank you, Dr. Thanks for introduction and invite me to attend this forum. It's my pleasure. I am an endocrinologist in Beijing Trial Hospital and Capital Medical University. I see maybe 500 patients a month. From clinical view, we find vitamin deficiency is much prevalent in China at every age. In addition, serum level of our patients are lower than North American from the literature. In addition, females have much lower vitamin levels than males because Chinese females pursue fair skins. It's very popular. In addition, Chinese physicians lack awareness of vitamin deficiency because they overly concerned about vitamin D poisoning. And vitamin fortified milk in China has not been widely used in China. And in China, we have limited vitamin D supplements available in hospital and pharmacies for the vitamin D use, the prevention and treatment. This is our research in 2012 and to 2013. We enroll over 5,000 Beijing residents, and we found vitamin D deficiency, the prevalence of vitamin deficiency lower than 20 nanogram per liter is 87.1%. Is highly prevalent. And the female have more 89% and higher than vitamin D level is lower than males. And we compare the vitamin D levels for China and Americans. Different. This data from China National Nutrition and Health Survey of Child and Lactating Mothers in 2016 and to 2017. They enrolled for children and adolescents 6 to 17 years old, and the vitamin D deficiency lower than 20 nanogram per liter is about 66%. And the median serum vitamin D level is only 17.7 nanogram per ml. And their females have lower level than males. About the lactating nursing mothers, we can see there are much difference in different areas. Beijing and Gansu province is because north of China, the only level is 16 nanogram nanomole per liter. The highest level at Guangdong. Guangdong is south of China, and the average level is 29 nanomole per liter, equals to 12 nanogram per liter. So it's very extremely low, even in Guangdong province of South China. Another materials we see from Beijing, they enrolled about 70 pregnant women. The average level is 11.5 nanogram per liter. So it's just the same as previous data. And we compare the results of China to American data. American pregnant and lactating women have a 612 nanogram per liter. It's a much difference. So in China, we have 10 nanogram per liter lower in China than the United States. And vitamin D deficiency, prevalence of vitamin deficiency is much higher. In addition, we can see from national survey for the about 5 years interval, we can see the pregnant women in China in 2010, there are 15 nanogram, and 5 years later, it's decreased to nanogram per liter. So the situation is much worse. So from the clinical routine, we can see many severe vitamin D deficiency patients. Here, severe vitamin D deficiency nursing woman. She is 28 years old and present with multiple rib fracture.
I can see them as well.
The nursing mother have
Which
vitamin D level only 5.6 nanogram, and the PTH level 128 picogram per milliliter. So she had never supplementing during pregnancy and lactation period, because in China, the calcium daily intake and vitamin D intake is much lower. The calcium intake daily is less than 400 milligram per day. Most Chinese, the average Chinese calcium intake less than 400 microgram. The nursing mother breast 7 months daughter. In addition, he frequently squeezing out milk for freezing for later use. Just almost 3 liters per day for months. So maybe because she have limited calcium and vitamin D intake and frozen for 3 liters milk every day, so have severe osteoporosis and severe rib fracture.
Yeah, thank you very much, Dr. Ning, for sharing the important information here. It really reflects the importance of educating the public worldwide, and particularly in countries like China with over 1 billion population. And so we have a lot of work to do. And over the past over more than 10 years, I think I've been trying very hard to get the nutrition, also medical medicine to China. But we are making progress, but it's slow. Yeah. All right, Jan.
Okay, well, sorry about the slide issue. I could not see them myself. Hopefully other people could. So up next is Dr. William Grant, and he will be covering the topics of cancer incidence and mortality and brain health. Dr. Grant, can you share your slides?
Okay, let's see here. I don't see the share. Oh, wait, here's share. Okay. Here we go. Slideshow.
Okay, I can
From
see
beginning?
those.
Okay. Okay. So, yes, I'm going to talk about vitamin D and cancer risk reduction and brain health. Disclosure, I have received funding from Biotech Pharmacal Inc. in Fayetteville, Arkansas, a supplier of high-quality vitamin D and other supplements. I will first of all discuss the following types of studies: geographical ecological studies, prospective cohort studies, randomized controlled trials, and studies of mechanisms. So for cancer, it was the ecological studies that first identified that UVB and vitamin D reduced the risk of cancer. And that was done by Cedric and Frank Garland, who were beginning graduate students at Johns Hopkins School of Public Health in 1974 and published in 1980. And Dr. Garland has been very closely associated with grassroots health. Now, here's the map of cancer mortality rates for colon.
Dr. Grant, make sure you're changing your slides.
Yeah,
We're
okay.
still on your cover slide.
Oh, I'm seeing a new slide. You don't see a new slide?
No,
Okay, let's do share again.
I'm sorry, everybody. Technical difficulties.
Share. Do you see it now?
Yes.
Okay.
Perfect.
Okay. So what you see on the right-hand side is colon cancer mortality rates for males, white males, 1970, 1994. Darker red means higher mortality rates. Darker blue means lower mortality rates. And on the left, we have the solar UVB map for the United States for July 1992. And you see that the pink is very high rates in the Southwest. Blue is very low rates, especially in the Northeast. And the reasons for this distribution is that the Western United States has higher surface elevation and a thinner stratospheric ozone layer because the air masses try to cross the Rocky Mountains. And so the higher solar UVB is associated with lower colon cancer mortality rates. And here's the same similar slide for breast cancer. And you see more or less the same pattern, except along the West Coast, there's a little bit more mortality rate because of clouds and fog along the coast. I published a paper in 2002 which looked at the correlation between solar UVB and this is for breast cancer mortality rates. And you see that when you get out to the higher UVB regions, you have about 2/3 as much breast cancers in the in the lower regions in the Northeast. So the ecological studies, like I just showed, are very useful in giving the sort of the satellite map, the general distribution of things like cancer. Now, the more common observational study is the prospective cohort studies. In such studies, participants are enrolled. Values for things like vitamin D level and BMI and so on are measured. Participants are followed for several years, and participant health outcomes are compared for the values of things like vitamin D level. But there's a problem in that the values of things like vitamin D concentration change over time, and as a result, the cohort studies underestimate the benefit of vitamin D. And I've shown this in a graph here published in a paper in 2022. This shows the odds ratio for colorectal cancer for males and females as a function of follow-up time for the cohort study, going from 1 to about 13 years. And you see that the solid line is the regression fit for males, and it shows a very steep change, whereas the dashed line is for females. Well, it turns out men are more likely to have outdoor occupations, be outdoors more, etc. And so their vitamin D levels are more likely to change with time, whereas females who spend more time indoors don't have that. So this shows that if you go down to the 0 time interval, you would have about the same 25% reduction in colorectal cancer comparing high versus low values. Now, randomized controlled trials, most of the vitamin D clinical trials have been based on the guidelines for pharmaceutical drugs. And in a drug trial, the people in the control arm are given a placebo. They're not given the drug of interest. But in vitamin D, there are so many sources of vitamin D, and most of these trials have enrolled people with high vitamin D levels, given too little vitamin D, and analyzed the results depending on whether we're treated with vitamin D or not. Haney's guidelines suggest that you measure 25-hydroxyvitamin D and include participants only with low values, give sufficient vitamin D to raise 25-hydroxyvitamin to achieve health benefits, measure the achieved 25-hydroxyvitamin D, and analyze results with respect to achieved concentration, not the vitamin D dose. Very few studies have followed these guidelines. Now, here's the quick review of the VITAL study. This was a study conducted by Harvard University starting in 2012, enrolled over 25,000 participants, including 5,000 African Americans. Half received 2,000 IU per day and half a placebo for 5.3 years. The mean baseline 25-hydroxyvitamin D for those providing values of about 31 nanograms per milliliter. That's well above the average value in the United States. In addition, all participants were permitted to take up to 600 or 800 IU per day vitamin D, as well as spend time in the sun. One can almost say that this trial was designed to fail, and fail it essentially did. For the entire group, there was only a significant 25% reduction in all cancer mortality rate, but no significant effect on cancer incidence. However, for those with BMI less than 25 kilograms per millimeter squared, there was a significant 25% reduction in cancer incidence. For African Americans, there was a barely non-significant 25% reduction in cancer incidence. The abstract is what most physicians read, did not mention these beneficial results. The paper is published in New England Journal of Medicine, an advertising arm of Big Pharma, it limits abstracts to one outcome. And so most doctors did not realize there were benefits. Now, it turns out that vitamin D has much more benefits for cancer mortality rates than it does for incidence rates. Now, here is the results of the analysis of breast cancer incidence for participants in 2 randomized controlled trials conducted at Creighton University by Joanne Lappy and Robert Heaney, and also participants in the Grassroots Health Volunteer cohort study. And what you see is that even out to 70 nanograms per milliliter, there are reductions in risk of breast cancer. But if you look at where the VITAL study was, around 30 nanograms per milliliter to 40, you're going to see very little effect. And that's what was found in the VITAL study. Very little effect on cancer incidence. If you look at the mechanisms, vitamin D reduces cancer incidence through effects on cells and maintaining tight outer layers of the organs. But there are many other risk modifying factors that also affect cancer incidence, such as smoking and pollution and obesity and inflammation, et cetera, et cetera. And so that's why you don't have much of an effect on incidence. But when it comes to progression of cancer, cancer needs to develop blood vessels around the tumors to receive the nutrients for growth. And vitamin D is one of the few, has one of the few mechanisms of reducing these angiogenesis around tumors. And vitamin D is also one of the few molecules that are going to reduce metastasis in the surrounding tumors. So that's why the effect on mortality is stronger than the effect on incidence. Moving on to brain health now, it is well known that some dietary factors and lack of exercise for many years can increase the risk of developing poor brain health. And this is going to take place over 5, 10, 20 years. You have things such as cognitive impairment, where the brain, you don't think as well, vascular dementia, Alzheimer's disease, and stroke. And what I'll show in the next few slides is that maintaining higher serum 25 concentration, say above 20 to 30 nanograms per milliliter, can greatly reduce the risk of these adverse effects, even in short periods of time. So here's what I've done here is I've plotted results from prospective cohort studies as a function of time for the follow-up. This is from 5 to 13 years. And what you see is that if you go out to 13 years, you get a relative risk for cognitive impairment of 1, essentially no effect. But if you've done a study for 5 years, you have that the low value is going to give you about a 70% increased risk of cognitive impairment compared to having higher values. Now, this is, if you take all the values and average it, which is what's done in most of the analyses, you would find about a 20 to 25% effect. And this now shows as a 60% effect. So what this means is that the published meta-analyses of such studies have greatly underestimated the benefits of vitamin D, which may be one of the reasons that vitamin D is not being promoted very much for improving brain health. I looked at the same thing for dementia. Again, the relative risk for a 13-year study is around 1. The relative risk for dementia for 5 years, about for low versus high, is around 2.1. So you've got and that compares to about 30% for the average for all. And then for Alzheimer's disease, the same, very similar to what was found for dementia. Now, I've also just recently looked at stroke. And so here's the typical what's called a forest plot. And they, as you see that when they average these about 20 studies, they find a relative risk of about 0.78 or 22% reduction for high versus low vitamin D levels. But I noticed in looking at this that the second study by Judd et al. Was done for 3 years, and the Scabby et al. Study was done for 10 years. And the 3-year study had a strong beneficial effect. The Scabby effect had a negative effect. So I plotted these again versus follow-up time. And it turns out that from 1 to 10 years, there's a very strong linear relationship showing that at 1 year, there's a 60% reduction in risk of stroke for having 25-hydroxyvitamin D greater than 20 nanograms per milliliter versus less than 10 or 20 nanograms per milliliter. Whereas you get out to 10 years, you've got no effect. And if you go beyond 10 years, you have no effect. You have even shows a modest effect. But that's just accidental because you no longer have any real effect of the because of long follow-up. So the implication is that having vitamin D levels higher than 20 or 30 nanograms per milliliter can reduce your risk of stroke, and as I've shown, the other effects like Alzheimer's disease. And it probably happens over a very short period of time. In the manuscript I've shown that there are many number of studies showing that if you look at 2 to 4 to 6, up to 6 months of supplementation of vitamin D, you do get significant improvements in brain health. So this is suggesting that vitamin D has a very important brain effects for brain health over the short run. For further information, I recommend scholar.google.com as the best, one of the better places to look for the information, because it shows you how many papers have cited each paper. It shows you who else has cited this paper. It shows you where you get a free open access version of the paper. PubMed, of course, is useful. Then there's vitamindwiki.com. This is a very comprehensive website maintained by Henry Lahore, a retired engineer who's now devoting his life to putting as much information about vitamin D as he can on his website. And of course, Grassroots Health. Thank you.
Thank you very much, Dr. Grant. Okay, we have Dr. Aileen Burford Mason, who was having some issues earlier with her audio. Dr. Burford Mason, are you here? All right, Dr. Grant, can you stop sharing your slides, please?
Okay. Stop share. Yes. Okay.
Thank
Sorry.
you. Okay, I see you. There she goes. Okay. All right, we still cannot hear you.
So, very interesting to join this symposium this morning. And I think some of what I'm about to say has been already covered, but I don't think it will do any harm to repeat it. So, how do I, there. So, I'm talking about the immune system and briefly giving an outline of the important elements of the immune system that we think about. We have innate immunity, physical barriers, white blood cells and neutrophils and macrophages that will engulf and destroy viruses and any infected cells. There are other cells that can perform this function, phagocytosis. And then we have natural killer cells that can directly recognize or kill infected cells. And it's important to realize that our innate immunity is present from birth. The response is immediate. We don't have any need for prior exposure. And so I'm interested in some of the data on pregnancy vitamin D because I think it's critical that vitamin D is optimal in pregnancy for the production of innate immunity in later life of the offspring. So neutrophils, as we know, are the first to the scene when there's infection, and in attacking and destroying and invading microorganisms, they increase inflammation. I think we need to realize that neutrophils, as a first line of defense, really we need to produce a humongous number of them every day. They are very short-lived. They need replacing every 2 to 3 hours, and we'll see that also is depending on the presence of adequate vitamin D. So the other aspect of immunity we look at is adaptive or acquired immunity. The main players are the lymphocytes, B and C lymphocytes. C lymphocytes being divided into a number of subcategories. So B lymphocytes simply produce antibodies, and these will bind to any microbes, and that flags those microbes for destruction. The T lymphocytes are present and necessary to activate the B cells. You have the helper cells, those help B cells and other immune cells activate. And you have the regulatory cells, the Tregs, used to be called T suppressor cells because they suppress immune responses, but more importantly, they actually regulate whether the immune system is on or off. And then you have cytotoxic T cells. So it's the cooperation between the T and B cells that control immune responses. And of course, acquired immunity is adaptive immunity is acquired either through exposure to an organism or vaccination. And the other important thing about acquired immunity is that some of the B and T cells will become memory cells, which can respond rapidly to acute infections when we're exposed to the same organism. These cells can be overactive. I think we saw a lot of that during COVID, and an overreaction of these cells can lead to either prolonged inflammation or autoimmune diseases like lupus or rheumatoid arthritis, etc. So I think it's important to recognize, and I think the general public did not recognize during COVID that it was actually resolving the immune system that was a problem. Switching it on is fine, but we also need to be able to terminate the immune response. If not, we are going to have ongoing inflammation, and this can progress to autoimmunity. And the signs we have of a dysregulated immune response where termination was not occurring were the things we were all scared of during COVID: the cytokine storm, multi-organ failure, and acute respiratory distress syndrome. So vitamin D, I think if there's one quote that crystallizes really the central importance of vitamin D in immunity, it's this one from Professor Carsten Giesler, who was commenting on their paper in Nature Immunology in 2010. And he said, when a T cell is exposed to a foreign pathogen, it is an immediate biochemical reaction and extends a signaling device or antenna known as the vitamin D receptor, with which it searches for vitamin D. This means that the T cell must have vitamin D or activation will cease. If T cells can't find enough vitamin D in the blood, they won't even begin to mobilize. So I think this is just a lovely quote that will put a good perspective as far as immunity is concerned. So we know that really one of the early interests in vitamin D was in preventing upper respiratory tract infections. And going back to the 2010, this study in Japanese school children, where they gave a modest dose of vitamin D, 1,200 international units of placebo, and they gave it over the winter months, which is very important. Many studies do not restrict the participants to any particular time of the year. And so the primary outcome they were looking at was laboratory confirmed influenza A. And they did find an impact of even that modest dose of vitamin D, where there was a 11% roughly occurrence of flu in the vitamin D group compared to nearly 19% in the placebo group. But what was important is that many of those children also suffered from asthma, and in those children, vitamin D did reduce asthma attacks. So 2 occurred on the vitamin D, but 12 on the placebo. So this is a small study, but it was, I think, very useful one to look at. So looking further forward, this is a systematic review and meta-analysis of vitamin D for preventing upper respiratory tract infections. It found 25 eligible randomized controlled trials, and the results were quite spectacular. So in general, based on all the studies that they looked at, which included heterogeneity, like you wouldn't believe, massively different doses, time of implementation of the study, etc., they still saw a 12% reduction of respiratory tract infections, which we feel gave doses of vitamin D. They found 19% reduction. And now they did find, and this has been mentioned earlier on, no benefit of bolus or monthly dosing. And I really do think we should take part, in fact, of particularly daily dosing if we're looking at vitamin D supplements. What was really important, though, was the biggest benefit was seen, as we see in many studies, of giving vitamin D to those with very low levels of vitamin D, deficient levels, below 10 nanograms, I should say, per mil, or 25 nanomoles per liter. So with regard to COVID, I would say categorically that COVID has set back vitamin D research by 2 decades. So much bad research was done. There was urgency about it. There were many non-peer-reviewed publications, preprints, which seemed like a good idea at the time, but it just got a lot of very poorly designed studies received attention. So this is one meta-analysis, systematic review. And one thing to realize, I think, about reviews and especially meta-analysis, the researchers set the guidelines for what they will include in the study. So in this particular analysis, there was no reduction of major related outcomes like mortality, ICU admission, or mechanical ventilation. But it did comment that there was a huge difference in design, drug dosage, and population characteristics. And so because of that, they say it's difficult to come to any conclusion and extrapolate the data to a large population. And that is what we're trying to do all the time. Say, can we give general advice from specific studies and interventions? So this is a more recent one, very recent one. And they looked again at the impact, just like Dr. Grant was saying, on mortality and in COVID patients. And certainly they found 19 randomized controlled trials they were prepared to review. And there was a significant reduction in all-cause mortality. We heard that after COVID that, okay, they didn't die of COVID, they died of the cancer they had, or they died of the diabetes they had, because concurrently, many of them, of course, did have coexisting conditions apart from COVID. But when you look at all-cause mortality, there was a 28% reduction with vitamin D supplementation. And again, it was more pronounced, 43% reduction in severe cases of COVID. Of course, autoimmunity is a huge issue when we're thinking about vitamin D adequacy. So the VITAL study has been mentioned before, and I like the comment that it might well have been designed to fail. One could think that for sure. Huge numbers of people given 2,000 national of vitamin D, and they were at the same time. Some of them were also given omega-3 fatty acid supplements or placebo, and this is very recently reported by them that they did find a 22% reduction in autoimmune disease development in those taking the vitamin D, whether it was with the omega-3 fats or not. They did find some reduction that was non-statistically significant with the omega-3 fats alone. So when you look at the literature, you see strong evidence of links to vitamin D insufficiency, and both the onset and progression of numerous autoimmune diseases. Multiple sclerosis is one of the best studied, rheumatoid arthritis, type 1 diabetes, and celiac disease and autoimmune thyroid disease, which often coexist. So, as other people have mentioned already, the problems with clinical trials of vitamin D are multiple. There can be no control group. This has been said over and over again. You cannot ethically create a group with 0 blood levels of vitamin D. And this contrasts with drug trials, where, of course, you know that the control group are totally free of the test drug. There's no guarantee that either control or treatment group don't get extra vitamin D, either from sun exposure or supplements. It would be impossible to carry out such a study. And in fact, there are publications showing that in the VITAL study, people who were in the placebo group, their own personal doctors, family doctors, found that they were vitamin D deficient and gave them vitamin D or encouraged them to take it. So they were no longer even roughly a decent placebo. Dose matters. Trivial doses will show no benefit. And I know it's something we wrestle with all the time. What would be optimal? I think the most important thing is to say, what do people who are exposed to sunshine on a regular basis achieve? What sort of blood levels they would achieve? And some of those have been mentioned. And I found, for example, people who've never taken vitamin D or any other supplement in their life, in the middle of our Canadian winter, will go away for a week of sunshine, and they will come back with blood levels of over 300 nanomoles per liter. And so that's perfectly normal. Nobody comes back from a week of sunshine feeling unwell, and there's no danger in terms of mortality or acquiring diseases. So blood levels matter, and I think this is important work that needs to be explored more. It's not enough for us to know something, but everyone needs to know it. So we need to repeat research over and over again. Anyone who uses vitamin D clinically knows that they will give the same amount of vitamin D, will achieve very different blood levels. And those people, even with the 4,000, which is the upper limit at the moment, you will find some people in that, the odd person will still not achieve deficiency. So many of the trials don't even bother to check blood levels. So you have no idea who you're putting into that trial, whether they are vitamin D deficient or insufficient. And of course, as has been mentioned before, weight matters. And again, many of the studies do not even consider weight. So this is just a critical look at all the studies that have been done. And this is a direct quote. Large vitamin D randomized controlled trials have been designed and conducted over the last few years. The vast majority of these trials do not restrict their study population to individuals with vitamin D deficiency. And some even allow, as we've seen from other talks this morning, moderate vitamin D supplementation in the placebo groups. So no surprise that there's no significant outcomes in the primary, no effects on primary outcomes. I wanted just to throw one more idea into this, because I personally got turned on to the regulation of nutrition, of immunity by nutrition, by this 1979 paper by the late great David Herbin, an endocrinologist. And he wrote that T cell function depends on many key nutrients. And he mentioned vitamin C, the B vitamins, zinc, essential fats, the omega-3s. He didn't mention vitamin D at the time because really our focus on vitamin D came much later. We weren't thinking very much about vitamin D in those days. And he says inadequate intakes of any of these will compromise T cell function. And I think the important statement he made was that megadoses of single nutrients will only be minimally effective if intakes of other nutrients are inadequate. And so I went on to finish with this idea that vitamin D is not a drug, as many medical papers have called it. It's a vital component of the complex immune apparatus we need to manage appropriate immune responses. That includes fighting infection, preventing cold and flu, controlling inflammation, and preventing the development and progression of autoimmune diseases. But it does not work alone. Vitamin D can't carry the weight of all of these diseases on its own shoulders. It'll only be minimally effective if there are coexisting deficiencies of other nutrients. And the two, I think, are very important to consider are vitamin C and magnesium. And those two nutrients, we knew during COVID that those people who were in ICU were extremely deficient. Other studies have shown almost everyone in ICU is at scurvy level of vitamin C. Magnesium is required for every aspect of vitamin D, absorption, metabolism, binding to tissue. So magnesium is critically important. And in fact, as we've talked about before, if you take the criterion that you would see if someone with vitamin D deficiency, you see an increase in parathyroid hormone. You cannot make and mount a parathyroid hormone response without magnesium. And magnesium is not trivial or irrelevant deficiency. It is actually very widespread in North America. So I think we have to also remember vitamin D is critically important. We are not looking at it in any rational way as to what level of vitamin D is needed. We should be looking at the individual level, not those of us who work clinically are not so much interested in population studies as we are in what happens to the individual. And also remember that vitamin D is a vital component, but only one component of the immune apparatus. I just wanted to mention, I cover a lot of this in the book that I wrote during COVID, The War Against Viruses, How the Science of Optimal Nutrition and Healthy Wins. So those who are listening who haven't got much background in this might find valuable information there. Thank you very much.
All right. Thank you, Dr. Burford Mason. And my apologies for the audio. Hopefully everybody was able to hear her okay. We are slightly behind at this point, but our next topic is a very important topic. And I'd like to reintroduce Dr. Sunil Wimalawansa, and he's going to be talking about vitamin D safety and toxicity. And I just saw you, Dr. Wimalawansa. Where did you go?
The questions came up so far. There are several parties were asking about the dosings of the vitamin D. I hope that I might be able to answer that question. So there are various regimes to calculate the dose necessary, but we have published this particular article in Nutrient about a couple of years ago, simplified the way to anybody to calculate the dose of vitamin D necessary in a given patient. Because as we heard that vitamin D the requirement is going up with the BMI, the body mass index. So unless we adjusted the dose properly to given patient, i.e. it should be individualized, you may not able to achieve the expected goals. So just the point is that there's no single fixed dose of vitamin D for adults or children. It doesn't work. Secondly, it's the most important thing actually, not the dose you actually given, but the blood level of 25 hydroxy vitamin D, how much it reached, so that the blood level is sufficient to overcome the disease of concern. And I'm going to give a couple of examples after this. So what you need to remember is something like a very simplified version. In a non-obese adult, say 70 kilograms, 60 to 70, what the requirement is about 70 to 90 international unit per kilogram body weight. So the higher the body weight, the number will go up to about 4 or 5 times in the extremely heavy people. Now, before I show the other aspects, I just want to show you that vitamin deficiency can be occurred through any of these variability, particularly the inadequate sun exposure. Another interest of this group is to look at the vitamin D resistant, that requiring the very high doses of vitamin D to overcome the vitamin D resistance. There are very specific examples. Some of these are illustrated in these red oblongs. You can read that later. Okay. So how do you measure the dosing? How do you calculate the dosing and individualization? Human needs about 10 times higher vitamin D intake than the governments across the globe are recommending. This was addressed by Professor Holick, showing that the recommended dose in US, for example, or UK is still 600 international unit per day. So perhaps they all forget to add a zero at the end to make it 6,000, which makes it something reasonable. And also, he mentioned about the Institute of Medicine report. Again, they recommended the 600, but subsequent papers highlighted that significant error, including the major statistical blunder of calculating the daily requirement in the IOM paper. The issue is, unfortunately, many of these guidelines have been pivoting on this IMO report, which is flawed to start with, and which is, in fact, it's not a guideline. It's a recommendation to the public health, recommendation to the government, has been taken as a pivotal point to designing their guideline. Therefore, they are not unsuitable for their public. So I already said, such as the previous one, having the different minimum level, 20, 30, 40, is not worth it. What we need is a minimum level to keep people healthy. So something like 40 to 80 or 50 TA2 nanogram range will cover vast majority of the disorders where humans are getting affected. So this was slightly complicated. Let me go through for a couple of minutes. Y-axis, you can see the serum 24-hydroxy concentration in nanograms per mil, and the health benefits are illustrated on the y-axis taken as 100% as the maximum response. So it's obvious that during the vitamin D deficiency, when you increase serum level with supplements, whatever dose you're going to give, there is a significant effects on musculoskeletal benefits. So that's where all the guidelines are based on this 15 to 20 nanograms per mil to fulfill the requirement of the muscular benefit. But all the guidelines actually ignore the extraskeletal, the benefits. Some of them are already addressed, like the immune system and overcoming infection, cancer, etc. So the physiological range either can be taken as 40 to 80 or 50 to 80, which is not certain yet. But there is also an upper limit where beyond that you have to be extra careful. For example, over 115 nanograms per mil, there's a high incidence of hypercalcemia. It can cause problems, and one need to or one must avoid that happen. Particularly if you increase the dose without calcium restriction diet or taking calcium, this is likely to happen. But overall reported hypercalcemia complication from the supplement is extremely low, a few hundred cases only. And there's a very small group, 0.01%, with the rare disorders, vitamin D resistant, drug resistant disorder, which I mentioned previously, has requiring the higher doses to overcome those resistant. Here are the higher intakes needed, the condition needed for high intake. For example, when the baseline serum 25 concentration is very low, giving 10,000, 20,000, 30,000, even that will take several weeks or months to achieve the serum level. Their body deficit could be over 1 million. So these patients or people can be benefited by administering the upfront loading dose, either the single dose of something like 200,000 or divided dose by 50 international 50,000 units, one capsule, basically giving daily or every other day to rapidly reach in the serum level what is desired. So that will advance the benefits of vitamin D quite significantly. Then there are vitamin D resistance syndrome and higher body mass, people with intestinal absorption defect, particularly the bariatric surgery, going to need very high doses to maintain their serum level. So as those who are taking medication that increase the catabolism of vitamin D, like anti-epileptic, retroviral agents, etc. So this applies to not only for research, but also our clinic patients. So let's look at briefly the safety and the contraindication related to vitamin D. So hypercalcemia from overdose of vitamin D, as I suggested, is exceedingly rare. When happened in the few cases, is almost always due to mistakenly taken millions of international unit instead of they thought as thousands. So that kind of thing can cause, invariably can cause into trouble. So vitamin D toxicity cannot be diagnosed in isolation just by having the random sample with higher serum 24-hydroxy level. So toxicity is possible, however, when the level exceeded 150 nanograms per mil, but it must be associated with the clinical signs and symptomatology of hypocalcemia as shown in this slide. So this patient to diagnose as a vitamin D toxicity, in addition to the high serum 24-hydroxy level, they must have a hypocalcemia, they must have a hypercalciuria and suppress parathyroid hormone. Without that, making a diagnosis of vitamin D toxicity is incorrect. So relying on the higher serum level concentration of 24-hydroxy is a mistake. So what are the contraindications? There are a few people with the hyperreactive or hypersensitive to sunlight, as with the bullous disorders and erythematosis or SLE kind of this patient. They are not too exposed to the direct sunlight because they can develop a lot of adverse effects from sunlight. So those patients will benefit, however, with the vitamin D high doses. And there are genetic disorders like Williams syndrome. There are several others, very rare disorders, then they are producing or hypersensitive to vitamin D. And the third group is various granulomatous diseases like sarcoidosis, for example, can produce excess calcitriol within them and release into the circulation and causing hypercalcemia. It's not common, but can happen. So the other question asked commonly, and in fact the audience has already asked, what are the supplements needed in addition to vitamin D? Two answers. Firstly, when someone on the reasonable dose of vitamin D and the blood levels are reasonable, taking calcium supplement is unnecessary because the fractional international absorption of calcium increases automatically to reduce that deficit, even the diet has less calcium. So taking calcium is unnecessary when you're on a good dose of vitamin D. The other issue you actually need is supplements or cofactors, especially the magnesium is critical factor to vitamin D receptor interaction, as well as it is necessary for release of virtually all hormones from their secretory granules. So you can give hormones or they produce hormone, but in the absence of magnesium deficiency, they may not release the hormones back to the circulation. So as the previous speaker mentioned, that vitamin A, C, B, K2, zinc, boron, quercetin, omega-3 fatty acids, they all are necessary to optimize the immune system to get a better action in conjunction with the sufficient vitamin D. When this 25 hydroxy vitamin D exceeds 75 nanograms per milliliter, it's advisable to take K2, so also called MK7, either 100 micrograms per day or 800 micrograms once a week. These are the two commonest prescription preparations available in the market you can buy. So this is in part to alleviate the concern of possible or potential soft tissue calcification. Therefore, the excess ionized calcium, if any, will be diverted back to the skeleton. So it is quite reasonable to take K2 when you're taking a higher dose of vitamin D. This is my last slide. Just to summarize the previous presentation, vitamin D deficiency impaired immunity and also accelerate the aging process. It increased the illnesses, increased the COVID risk, as we saw the previous presentation. But more importantly, it also increased the comorbidities, which can lead to other problems like risk of death, increased complication, hospitalization, and indeed the hospital care. Thank you. Thanks for listening.
Thank you, Dr. Wimalawansa. I wanted to make a note again that this is being recorded. The recording will be available online after today. And I already have longer full presentations recorded with Drs. Wimalawansa and Dr. Grant. And I have additional recorded presentations scheduled with Dr. Burford Mason and others. So those will also be released prior or following this event. So next up, we have our question and answer session, and I apologize, we're going to have to cut it a little shorter than we were hoping. However, I do want to introduce the moderators of our expert panel as Dr. Michael Hollick and Dr. William Grant. And we did have several questions that were submitted prior to this event. You're welcome, because you're aware of those questions, you're welcome to suggest a one to start with because of our limited time. However, I do want to make time for some of those that were asking about side effects or toxicity, as well as I want to make time for one on prenatal health with Dr. Hollis.
So I think
I'd like, unfortunately, Carol Wagner didn't present today. So just a few things about pregnancy and vitamin D. Pregnancy is really an excellent place to study vitamin D because you see your results within 9 months of what you're looking for, unlike cancer and some of the other things. That being said, we've been conducting these pregnancy trials, randomized trials, since the early 2000s, and with some success. But the best results we had seen are not from our studies, or one I was been involved with, but was in studies conducted overseas, India, Iran, where their populations would mimic a drug trial, where vitamin D levels are very low, okay, and then they do supplementation, but they leave the low subjects alone. They don't supplement. We can't do that in this country. We have standards of care, but they can do it over there. When you look at those trials, the results are incredible, especially the results from 2018 from a study in Iran by Rastami that showed just incredible results on vitamin D supplementation. The final thing I'd like to talk about is the VDART trial. It was run at Harvard by Scott Weiss. It was a vitamin D antenatal asthma reduction trial, looking at how vitamin D would combat asthma formation, where vitamin D was given during pregnancy, and then the infants were followed at 3 to 6 years to see how it impacted their development of asthma, because the observational trial suggested that there would be a great effect. And to our dismay, we saw some results, but it wasn't what we'd hoped for. And what happened in the end, Scott Weiss, within the last year, went back, took all that data, reanalyzed it, taking baseline levels of 25D into account in these mothers. And this was published within this past year. It's in the Journal of Clinical Allergy and Clinical Asthma and Jackie, and it's a big journal in the clinical immunology field. Anyway, it was remarkable because what he found was when he controlled for baseline levels of entry, then the asthma prevention in pregnancy was remarkable, okay? As you would see, it coincided with observational trials. And that's how all vitamin D trials, including VITAL, should have been handled. They should have gone back, taken into account basal levels. It's as close to overcoming a confounding factor that you can, and then reanalyzing it. I've challenged VITAL to do this, and they refuse. They don't want to know the answers given that. And finally, how much vitamin D to take during pregnancy? If you look at the Weiss paper, taken all into account to get appropriate levels, Scott Weiss concluded from the reanalysis that 6,000 units a day was required to lift pregnant women into the levels that were suggested today of 50 to 60 nanograms. So in short, unfortunately, that's all the time I have to do, but that would be my recommendation.
Thank you, Dr. Hollis. I'm going to go ahead, Dr. Hollick, if you would like for me to read some of the questions, you do know some of those that were submitted. Which would you prefer?
Yep, please.
Okay, and I think I'll let this run about 10 minutes over. Hopefully that is okay with our panelists. All right. Could any amount of vitamin D cause renal damage? And then a similar question, what are your thoughts on vitamin D taken regularly having any possible ill effects on polycystic kidney disease?
So it's well documented that vitamin D does not increase risk for kidney stones. And if you take an adequate amount of vitamin D, and just like Bruce had said, 6,000 units for pregnant women, the Endocrine Society guidelines said that up to 10,000 units is the upper limit, is safe. There's really no evidence that it has any impact on kidney function. But when you're vitamin D toxic, above, say, 150 to 200 nanograms per ml, you begin to increase your ionized calcium phosphate, and as a result, you wind up calcifying blood vessels, including in the kidney, that can cause renal failure. Regarding polycystic disease, again, it's not really an issue to take physiologic doses as recommended by the 2011 Endocrine Society guidelines. It will not have any impact on kidney function, but certainly can have improvement in other health outcomes.
Okay, thank you. And all the other panelists, if you have anything to add to any of these questions, please feel free. The next set of questions, they were all based on how you can either overcome vitamin D resistance or VDR resistance, or for those who have, for example, a vitamin D receptor SNP, or certain genes that might affect their vitamin D metabolism. The questions submitted were, would you suggest supplementing to reach the higher end of the vitamin D scale? Any research to support this, and will maintaining a higher end serum vitamin D level help vitamin D do its job in these cases?
Bruce, would you like to take it? You're on mute.
Yeah, go ahead. You can.
Okay. So long story short, in my opinion, is we actually did a study and asked a simple question, which is looking at 600, 4,000, and 10,000 units a day, looking at 25-hydroxyvitamin D levels at 6 months, looking at gene expression analysis. And we showed a dramatic increase, 600, about 150 genes, on 4,000, about 300 genes, and on 10,000 units a day, raising blood levels in the range of 80 to 90 nanograms per ml. The level was around 80 to 90 nanograms per ml, and over 1,200 genes were being up and down regulated. But what we also found, which was really important, is that the degree of expression was substantially lower in about 40% of the people. So even though you had this increase in blood level, you didn't have as much of an expression. Now, why is that? Is it because of SNPs? Is it because of VDR polymorphisms? We just don't know. There's also the other issue, which is the 24-hydroxylase deficiency. You have to be careful if you have a partial 24-hydroxylase deficiency, because the amount of vitamin D that you take will be more efficiently maintaining your 25-hydroxy-D, because you don't have as much 24-hydroxylase to be able to down regulate the amount in your circulation. So typically, you want to measure your blood levels at 25-hydroxy-D. And I think, as everybody has basically been saying, 40 to 60 up to 100, we consider to be perfectly safe.
Thank you. The next question is, have you heard of people who feel sick, fatigue, muscle weakness, headache, systemic inflammation, anxiety, brain fog, etc., when supplementing with vitamin D, and what can account for this, and what should these patients do?
I've seen several patients like this and tried to understand what was going on, thinking about maybe it's the formulation that they're not responding well to, that it has nothing to do with vitamin D. And then I also have recommended, maybe you should get your vitamin D from sensible sun exposure, and using our app that's free, which is dminder.info. But for some people, they are very sensitive, don't understand why, but they can have GI issues. And just like you've said, they feel fatigue, and we don't understand why. So I try to keep them in a range of around between 20 and 30 nanograms per ml. That seems to work, but it's relatively small amounts of vitamin D. And what's interesting, by the way, about taking small amounts of vitamin D when you're severely deficient is that you have two different enzymes in your liver to convert to 25-hydroxy-D. And at very low levels, it efficiently converts it up to about 15 to 20 nanograms per ml. So taking 400 or 600 units sometimes helps them.
Okay, thank you. The next question was addressed specifically to Dr. Wimalawansa. Could you please answer what is the recommended dosage of vitamin D for someone suffering an autoimmune disease?
Oh, that's a pretty broad question. The couple of things. The administered dose does not guarantee what's the serum level of 25 hydroxyvitamin D. So taking 6,000, which is a reasonable dose, there will be a huge variability of the serum 25 hydroxy level in the community, especially those with autoimmune diseases, because the turnover of vitamin D is much faster in these patients. So it is one area that the measuring 25 hydroxy D is going to be very helpful in patient management and helping, despite Endocrine Society guidelines said don't measure vitamin D. So like that, there are indications. So the second thing, actually, to most of the autoimmune disorders, they're going to require the level closer to 80 nanograms per mil. So that seems to be the best area the autoimmune can be suppressed. Quick example: when I was in Texas, we had something like a 70 plus patient with multiple sclerosis with severe problems. So we increased their level to closer to 80, and their recurrences dropped by 80%. Unfortunately, we didn't publish that. 80% reduction of aggravation of the MS. So bullets saying pimples, like any other autoimmune disease, basically work with that way. So be careful of not overdoing, but taking reasonable doses, maybe between 6,000 to 10,000 or even a little bit more based on the weight, plus a little bit more will, I think, going to be helpful without having any adverse effects. Thank you.
Thank you. All right, let's see here. Now, I've had a few people submit questions during the live event asking if ethnicity can affect the need for vitamin D or the target vitamin D serum level.
In my opinion, at least based on my experience, seeing patients with vitamin D deficiency with all ethnicities for the past 40 years, I've really not seen any significant difference in responsiveness to dose. People of color are at a much higher risk of vitamin D deficiency. And like I said, if you're really, really deficient, even a smaller amount of vitamin D will help raise that blood level in the range of about 15 to 20 nanograms per ml. But to get above 30 and that 40 to 60 range, from my experience, people of color taking 5,000 to 8,000 units a day can able to easily do that, just like in the Caucasian population.
Okay, thank you. Another question which has been repeated in several ways. Is there any evidence about the deposition of vitamin D in adipose tissue and its sustained release into circulation, giving rise to the rationale for the use of weekly, monthly, or bi-monthly doses?
I guess I can help answer that one as well, because we've done a lot of studies looking at fat content of vitamin D. And we also did a study in patients with gastric bypass surgery. And we asked a simple question, right? Is that you have this very obese individual that has a huge amount of vitamin D in the body fat and now loses 50 kilograms of body weight over a period of a year. And even though there's a huge amount in the body fat theoretically released into the circulation, 25-hydroxyvitamin D levels did not change. And so I think it depends on the circumstance. I think our hunter-gatherers probably had stored vitamin D in their body fat, and during wintertime, living in northern climates, they were able to utilize that fat for energy source and release the vitamin D. But if you rapidly decrease your body fat content, you destroy the vitamin D. You don't really gain it. Your vitamin D half-life is about 1 day in the circulation. But it will definitely get into your body fat. And whether you take it every day or once a week or once a month, it's still, most of it gets kind of equilibrated in your body fat and then it's released back out to get converted to 25-hydroxy-D in your liver. The real issue is that taking vitamin D every day, we think is very important because there's some evidence to suggest that by maintaining your blood level of vitamin D, you reduce endothelial membrane alterations that are associated with inflammatory disorders and cardiovascular disease. At least an in vitro study showed that vitamin D was effective at stabilizing endothelial membranes. So and I think Bruce believes the same, is that maintaining a blood level of vitamin D is equally as important as maintaining your vitamin D status, which is 25-hydroxy vitamin D.
Thank you. Does anybody have anything to add?
I have a question on this one. Yeah. So there's a saying among some of the practitioners is that you need to wait for like a month or two after you're taking the oral supplementation of vitamin D for the vitamin D to reach the sort of a steady level because of the fat solubility. Fat solubility of vitamin D. So that doesn't seem to be the case according to what I just heard. Am I right?
No, quite the opposite. That's exactly correct. We don't understand it, but the blood level will continue to rise, and after about 4 to 8 weeks, it will plateau. And it plateaus for each individual dose, which is really curious. And that's why people always are worried that if you're on 5,000 a day for, say, 5 years, are you going to continue to raise your blood level? And you don't. You raise your blood level to around 40, 50 nanograms per ml, and then you maintain it.
So you do need to wait for like 6 to 8 weeks to measure it, and then you still maintain it daily.
That's correct.
Right. Thanks. Yeah.
Yes.
Okay, so next question. Have you had successful vitamin D treatment with children? Can children with slow development take up to 10,000 IU of vitamin D on a daily basis? And I've had somebody else also ask about autism. So can somebody briefly touch on the safety of vitamin D for children?
My recommendation, I think, is reasonable to follow the Endocrine Society practice guidelines of 2011, which is 600 to 1,000 units a day is very reasonable. For teenagers, I think they should be treated just like adults, 1,500 to 2,000 units a day. Autism is incredibly common. Vitamin D deficiency is equally common. So it's hard to know the association. But what we do know is that often children with autism are indoors. They're not exposed to sunlight. It's a major source of vitamin D. And that being vitamin D deficient, as you've heard from Bill Grant and from others, it does cause muscle weakness. It can maybe have some effect on your brain. So it is important, I think, for children, all children, to be maintaining an adequate 25-hydroxy vitamin D, and I think that they should be on 600 to 1,000 units a day.
Anybody else? And would you all agree that there is the same dose calculation for children based on weight? I believe Dr. Haney said it was 35 IU per pound of body weight.
So I think there's a little bit of controversy in this area. And the reason is that we typically recommend for infants, right, that are 10, 20, 50 pounds later on, they were getting 400 units of vitamin D a day. And their 25-hydroxy vitamin D levels are about the same. And so there may be a weight issue, especially for obesity, maybe in children, certainly in adults. And whether vitamin D gets incorporated into your muscles, as some have suggested, and maybe you need more vitamin D. For the most part, I find that the guidelines that were recommended in 2011 are adequate for children of all ages.
Okay, thank you. Just a couple more questions. We've had so many submitted, and thank you to everybody who has submitted them so far. And yes, we will be doing our best to post the answers to these online after the event. So this next question, when vitamin D is over 100 or 150, other than letting time lapse, if you wanted to lower your level, what actions can be taken to lower the vitamin D level? What signs and symptoms should we look for to determine the urgency and level of intervention to lower the level of vitamin D in the body?
Yeah. So I've seen several patients like this, and the 150 nanogram per ml that the Endocrine Society recommended in 2011 is a guesstimate. We really don't know exactly what level will cause hypercalciuria, because it depends on your calcium intake. And so as a result, if you need to lower it, and we had a case of vitamin D intoxication, is that we told the individual to stop taking vitamin D supplementation, stop being exposed to direct sunlight without wearing sun protection. That will all help. I don't see any reason to take anything that would increase the catabolism. I mean, glucocorticoids can do that, but if you're vitamin D intoxicated, glucocorticoids is often suggested as a way for treatment. But you really care about is initially hypercalciuria, followed by hypercalcemia, hyperphosphatemia, decreased kidney function, and then many of the consequences. And in patients with sarcoidosis, as you've heard before, you need to be very careful, because a 25-hydroxy-D above 30 nanograms per ml can cause extrarenal production in the macrophages, increasing hypercalciuria and ultimately hypercalcemia.
All right, thank you very much. And before I close out the question and answer session, would any of the other panelists like to address a question that you've seen come up or make any additional statements today?
I would like to add one more comment to Professor Hollick's description. So the symptomatic issues with calcium toxicity actually is a manifestation due to high ionized calcium. So the treatment is a severe symptomatic hypercalcemia or high ionized calcium. It's very similar to what we deal with cancer-induced hypercalcemia, because the cause is the same, higher raised ionized calcium. Some of them might need to admit to the hospital to rehydrate them, and sometimes the diuretics will help to expedite the reduction of calcium. But there's no specific treatment necessary with the reference to vitamin D-induced hypercalcemia. As he said, it's going to come down. It takes weeks, sometimes a little bit more longer, as long as you keep the patient symptoms free. Symptoms due to hypercalcemia, like irritable heart issues, dry eyes, nausea, vomiting, dehydration, mental confusion, that kind of thing. Most of them are due to dehydration. So that's the key thing to address at that particular stage.
Thank you. Any of my other panelists have anything else to say? No. Well, I certainly appreciate you staying on a little bit longer. We probably have about 5 minutes left. At this point, I would like to offer the floor back over to Dr. Richard Chang, as he had some important take-home messages to share with everybody.
Thank you very much. I will just summarize my understanding and also sharing with for the general practitioners and the let me see, how do I share, and the consumers, and also some of my experience in my practice. Can you see the screen?
Yes.
Go to presenter view, though. Yes, there we go. Perfect.
Easy. Okay. All right. So basically, thank you for all the experts. And here we learned that vitamin D is safe, affordable, and essential So why still the global deficiency? I just have a few slides, and this is about me. I'm going to skip. So today we learned that vitamin D is both safe and has a very broad safety window. It is effective for virtually every aspect of our health, from head to toe. And I'm going to go cover a little bit more. And it is also very affordable and widely accessible. So why do we still face a global pandemic of vitamin D insufficiency and deficiency? And I remember a study not long ago of the National Health, the NHEC, of the United States, that's showing like 90-some% of the people in the United States surveyed were deficient in vitamin D. Okay, so this is a summary of the comprehensive health benefits of vitamin D. Today we discuss some of them. Prenatal and newborn health, cancer prevention, brain health, cognition, sleep, mood regulation, bone dental health, immune system support, autoimmune disease reduction. Let me add a little bit here. Personally, during the pandemic, I've been doing a lot of consultation globally, and with vitamin C and all the other antioxidants. Vitamin D has been always part of my integral or holistic package. I always start everybody on 50,000, yes, 50,000 IU every day for at least 7 days for 10 days, and plus vitamin C and others. We have saved quite a few people globally from ICU. And on the autoimmune disease part, high-dose vitamin D3 has been my integral package for many years. I have treated at least dozens, if not hundreds, of patients with autoimmune diseases, in particularly Hashimoto's and the psoriasis type of autoimmune diseases. I start them routinely at 30,000 IU vitamin D. Of course, I will go over some of the we measure and everything. We haven't seen any side effects so far, and we have been able to successfully reverse many of these autoimmune diseases, and in many cases, complete reversal with the complete turning to negative or normal of autoantibodies. And inflammation, as many of our panel experts mentioned, heart health and ASCVD, muscle function, exercise performance, physical endurance. This is of particular interest to me since at 85, I competed with young people in their 30s and 40s on badminton court at least 4 or 5 times a week. And of course, I do have a complete package, including vitamin D. I routinely take 5,000 to 10,000 IU daily. In my practice, I routinely recommend 5,000 IU to my patients and clients, and I haven't found anybody over the 100 nanogram per mil kind of limit usually I set. As a matter of fact, I found that most of people still don't quite reach the 50 nanogram per mil level, and that's what I've been finding. And also type 2 diabetes. As we know, the metabolic problem, diabetes, obesity are rampant worldwide. The vitamin D has a significant role in this area. Anti-aging and skincare, yes, the beauty as well. Vitamin D, interestingly, for sexual health as well. All these health benefits are being part of the manuscript we're preparing with references. So these previous 2 slides established, as the experts here mentioned, that the vitamin D has very important health benefits covering practically every aspect of our health. And the next one is that it actually is very safe with a very broad safety window, as we mentioned. The routine dosage has been mentioned, including like from 40 to 60 nanogram or 50 to 80 nanogram, or even stretch a little bit to 100 nanogram. That's for the normal range. However, we know, as Dr. Hardick and many other experts mentioned, that many studies show that vitamin D can be safe up to 150 or even 200 nanogram per mil, particularly under physician supervision. So it's very safe. So the question, of course, why do we still have a global pandemic of vitamin D deficiency? Here's just a slide that I routinely check when I recommend high dose vitamin D to my patients. I'm not going to read it. If you can look at it later. So one other thing I want to mention, since we mentioned about the vitamin D, some people also ask a question. In the paper we recently submitted on the also molecular medicine, also molecular.org, I was a little bit surprised too when I wrote this paper. Acquired vitamin D resistance. Basically, there are so many factors that can affect practically the effectiveness of vitamin D, as we mentioned. And including, I didn't list them here, the paper, the title is Understanding and Addressing Vitamin D Resistance. Basically, I found that practically the lifestyle, the unhealthy diet, the toxins, the micronutrients like magnesium, C, K, zinc, and others, and even hormonal balance or lack thereof, exercise, they can all have an impact on the effectiveness of vitamin D. Therefore, my message here is that when we look at vitamin D, we need to look at it holistically, not just the dosage of vitamin D you are taking, but also the other factors. And so we need to go ahead, test, and supplement. That's my message. And finally, thank you all. Thanks for all the experts, and particularly Dr. Harlech, Dr. Grant, Dr. Wansa, and others. I'm sorry for the names. And thank you, Dr. Jen Ariano, for the lot of. I've been lazy. I've been taking the backseat. But thank you very much for the organization and time and the efforts. She putting a lot of time and efforts. She really did the whole thing. Thank you so much. And also thank you, Andrew Kusiana from the International Society for Autoimmune Medicine for helping and also the technical support. Thanks to Mike Passwater at the Auto Molecular Medicine News Service for initiating and make this event possible. And again, also thanks to Mike Stewart, CEO of the Reardon Clinic. He's been putting a lot of help supporting the publishing and everything else at the also molecular medicine. Thank you. And hopefully you are like me. Hopefully we're not being money driven like the big pharma and everything else. I'm here for one purpose and one purpose only. I want to learn how to live healthier, happier, and hopefully longer life. And hopefully we all have the same goal. Thank you very much. Jane, back to you.
Thank you, Dr. Chang, so much. And thanks to everybody else who's here. If you could stop sharing your slides, I have just a few others to share. But just to piggyback on what Dr. Chang was just saying, I think everybody here would agree that vitamin D is really what's called the lowest hanging fruit. It is not only safe, effective, inexpensive, but it's one of the most to create some of the biggest improvements in health and decrease disease risk, lower healthcare costs, and all of the above. So let me just share my screen for a couple of closing slides here. And so just a reminder that everything has been recorded, and we have additional presentations that will be recorded and that will be posted to Grassroots Health and orthomolecular.org, as well as papers, including the manuscript that Dr. Chang just mentioned. There is an upcoming vitamin D symposium on November 1st and November 2nd. Again, if you are new to this information, soak it all in while you can. There's several amazing speakers, some of whom were here today, who will be presenting in that November symposium, and you can use a coupon code, those of you who are here today, to save 10%. It's Grassroots10. So make sure you go to their website down there at the bottom, areyouggettingenough.info. And finally, your support matters. We'll continue to support vitamin D advocacy, education, and research. And again, thank you so much for joining us today.